Good morning, everyone. Welcome to today's California Aging and Disability Research Partnership meeting. I'm Amanda Lawrence. I'm Project Director for California's Master Plan for Aging, and happy to welcome you here today. We are meeting in the virtual space only. We have live captioning available through the webinar, and all of our slides, the transcript, and the recording will be posted to CalHHS's Master Plan for Aging webpage. Please update your name in Zoom, members of the committee, by left-clicking on the three dots in your over your video stream, and you should see a menu. And then please go ahead, hit rename, and go ahead and rename yourself. So something more specific than CADRP member. Here's the membership today. We'll be joined by several experts in research and data in the aging and disability spaces. Welcome, everybody. And our agenda, a very high-level agenda. Just wanted to say, after we do introductions and updates, we're really going to focus today on those Master Plan for Aging key outcomes. So we'll have discussions on housing, homelessness, transportation, behavioral health and isolation, and the caregiving workforce. We do have public comment scheduled at the end of the meeting. I'll share these instructions at that time as well, but essentially, if you're joining audio by the phone, please hit *9 on your dial pad, or if you're attending on your computer via webinar, go ahead and click the raise hand button, and it'll add you to the queue, and we'll call on you when it's public comment time. And you can always email us at engage@aging.ca.gov to send any public comments or input to the Master Plan for Aging specific to this committee or any topic in the Master Plan. I'm going to go ahead and hand it over to CDA's Director, Susan DeMorris, and California Health and Human Services Agency's Elizabeth Stephenson for welcome and opening remarks.
Thank you, Amanda, and good morning and happy Friday to everyone. Thanks for joining. I'm really looking forward to today's agenda. I know you've moved away from the word beacons, but I think of this committee as a beacon. It's just so refreshing when we have our heads down doing the work to be able to focus for a couple hours today on where we want to go and the impact that we want to measure. And it's working with our impact committee, the implementing the Master Plan for Aging in California Together committee. It's been great to watch the evolution from 3 years ago. We just want to collect some data, and then we want to report some data, and then we want to analyze some data. Then we want to look at results and deliverables. Now we're talking about outcomes, and ultimately, with your help, the goal is impact, collective impact. So thank you all for your commitment to this advisory group, and I'm especially thrilled today, your foresight in focusing on behavioral health and isolation. We're just thrilled that the governor and Secretary Galley included $50 million for older adult behavioral health in the May revise that came out a week ago. So we're just thrilled that we're focusing on that in lots of ways, with funding and with data and outcomes. And I just want to give a shout out to Ross. Has been just a fabulous, fabulous, fabulous addition to the CDA leadership team. And we're just so grateful for the resources that have been given to our department to do this work in partnership and collaboration with the Center for Data Insights and Innovation and the California Health and Human Services Agency. So Elizabeth, welcome to you. Thanks for being here today, and I'll turn it over to you now.
Thank you so much, Susan. It's fantastic to be here. And it's so great to have this opportunity to participate in this partnership with you. For those of you who don't know me, my name is Elizabeth Stephenson, and I am the Acting Deputy Director of the Insights Lab at the CalHHS Center for Data Insights and Innovation, or CDII. I know you have a packed agenda today. I'm really excited to listen to this conversation, but I also wanted to share with you a new development over at CDII. I think, as you all know, we've been developing the Agency Data Hub, which is a secure cloud-based data sharing ecosystem. And in the next month, in June, we will be rolling out the legal framework to make Data Hub services available to CalHHS departments. So the legal framework is a document called the Participation Agreement. And in the next few weeks, our Chief Legal Counsel will be reaching out to departments to request a designated attorney to review that legal framework. And we'll also share out that document with key stakeholders of each department, along with an orientation package that really is designed to walk through key information. Once all the departments have had a chance to review and add feedback, we'll be sending the participation agreement out for signature. So really exciting milestone. We will also be having a webinar to sort of give more information for those who are interested in diving in a bit. And in terms of Data Hub services, we're going to be starting out with a pretty well-defined scope. We have our 2 dashboards, client linkage, and the eSIDS effort. But we are really excited to start conversations with our partners and see what's possible to move forward with next. So looking forward to talking about that more in the future.
Thank you, Elizabeth. We'll be on the lookout for that. And now I'm happy to turn it over to Sarah Steenhausen, our Deputy Director overseeing the Division of Policy, Research, and Equity here at the California Department of Aging. Welcome, Sarah.
Thank you so much, Susan. It's wonderful to see you all here today, and I'm just so excited to be joined by all of the great CADRP members online. So I'm going to give a very brief update on what is going on with the Master Plan for Aging. First, I just want to kind of build off of what Susan was talking about, a really, really significant effort underway on the behavioral health side for older adults. You know, we heard loud and clear from stakeholders during our day of action last fall that we really need to double down on our work to address the behavioral health needs of older adults. And we've developed kind of a multi-pronged strategy in this space, but most recently, Susan and the CDII team held a series of 4 listening sessions across the state to understand the needs at the community level of behavioral health and older adults and their behavioral health. And it really helped inform our understanding of the need to develop culturally responsive approaches to behavioral health that meet older adults where they are. And we're just so pleased that the governor has made this such a priority and proposed an investment of $50 million, as Susan noted. This investment will be over a period of 3 years. $30 million will be going towards building local community capacity to support our local partners in developing innovative approaches to address the behavioral health needs of older adults at the community level. $10.5 million for an ethnic media campaign to target older adults and raise awareness of available resources for targeting older adults in communities of color, immigrant communities, veterans, and people who identify as LGBTQ. And then finally, we're really pleased that we have $4.5 million set aside for the continued operation of the behavioral health warm line, which right now is called the Friendship Line. And really pleased that this strategy, we think, will help address some of these needs that we're seeing so rampant as a result of COVID, but frankly, that were there so much before COVID. So really excited about that. Second, I just wanted to note that we've been working a lot with our data team that is growing here in CDA, and Ross has been part of this effort, but we're really working on a broader data and enterprise development strategy so that CDA is really advancing its vision of what a really strong data approach looks like. And part of this is working towards the development of a consumer-facing web portal and contact center. It will take a few years to get this up and running, but our vision is a much more streamlined way for older adults and people with disabilities to get the information and support they need. So this takes a lot of effort on our data team side, but we're really excited to be working towards that. We also are developing our home and community-based services gap analysis to look at where non-Medi-Cal home and community-based services are across the state and what's a roadmap we need to develop to build out our infrastructure. And we're working on this in partnership with the Department of Healthcare Services that is undertaking the same sort of analysis on the Medi-Cal side of home and community-based services. This was a really critical effort underway because it gets at the issue of HCBS infrastructure. So even if we have a system that's financed and there are services available, we don't know that they're necessarily available statewide, and it's really important for us to build out that system. Third, I want to turn to Amanda Lawrence to give an update on the really exciting work that she and her team have been undertaking to launch our local aging and disability.
Yeah, we're really excited to have had the opportunity to distribute about $4 million to local communities to build out their own aging and disability action plans. And we so far have allocated $3 million to 15 different communities across California. They each get a grant of about $200,000, and it will really help the communities, just they need that boost of resources. They need to hire maybe a consultant, just as we did at the state, to help with stakeholder engagement. And so we awarded 15 communities, either cities or their counties, or perhaps counties that have banded together. We love that approach. And that's all across California. We've got rural in the north, we've got Central Valley, we've got the Bay Area, LA, Sacramento, like everywhere we have at least one or two awardees. We still have $1 million to go. So we're going to announce another round of RFAs in the summer. So if you have, of any cities or counties that would be interested to apply for a local grant, I'll post information in the chat. Really, these resources are so great, and it's for communities who have already done a little bit of legwork. They already have partners and they already have a focus on aging, but they need that help getting that plan made, that plan developed with that stakeholder and public engagement. So we're actually working, with Heather at UC Davis to evaluate that plan, but really excited to be able to offer that service to folks, and it's a great learning opportunity, and we're definitely going to document everything and share lessons learned, and a lot of course, data is the key component of that. So assisting these communities and doing their community assessments and also their evaluations is really important to the success of this program. And back to Sarah.
Thank you so much, Amanda. And I just want to also just underscore on another note, a lot of work that has been done by this committee on developing and launching the LGBTQ older adult statewide study. Just super, super excited about that. And thank you so much to our partners at Open House who've been just incredible partners in that space. And I know Ross has all the updates on that. And then I think finally, we're just excited to continue working with all of you on all of these issues, particularly advancing equity in this space. And our equity officer is just now bringing on, Marina Castillo Augusto is bringing on board our first ever tribal affairs manager. We really need to double down on efforts to outreach to the tribal community of older adults. And this is a space where our state, I think, could do a lot more. So we're very excited to bring Consuelo on board, who will be starting in early June. So those are our MPA updates. Of course, happy to answer any questions, but I will turn it back over to Susan or Ross.
I think I'll take it from here. Thank you, Sarah. Hi, everyone. I'm Ross Lawley. I'm the Chief of Research at CDII. And the focus of today's meeting will be around our MPA key outcome measures. So we're going to hear from our respective work group leads about these measures, and looking forward to hearing from you and gathering your feedback. But before we get into the outcome measures discussion, I'd like to introduce two new team members. So we're fortunate to have Angie Prony join the research partnership. And Angie comes to us from the School of Social Welfare at UC Berkeley. Extensive research background and expertise. She's going to be phenomenal for this group. Really excited to have her. And Angie, if you're on the call, can I hand it over to you for a quick introduction?
Sure. Hello, great to meet everyone. I am thrilled to be a part of this this community of scholars and leaders, and looking forward to contributing all that I can. So I think Ross did a great introduction. I'm a new assistant professor at the School of Social Welfare at UC Berkeley. I'm the director of its Center for the Advanced Study on Aging Services. I come as a licensed attorney as well in California. And then I also ran a nonprofit previously that focused on services and advocacy for LGBTQ plus older adults. So looking forward to contributing to this group. Thanks so much.
Thank you, Angie. We also have Evan Wallace, who joined CDA as a researcher. And Evan comes to us with a strong data and research skill set. We're really fortunate to have Evan on the team. He comes from the Department of Healthcare Access and Information before joining CDA, and he was instrumental in standing up a health workforce research data center there. He's going to be a tremendous addition to the CDA team. I don't think Evan can unmute right now, so so just welcome Evan, and he's going to be joining future meetings as a panelist. So we can go to the next slide, please, Amanda. Thank you. So to begin our discussion, I thought it'd be helpful to kind of take a step back and ground ourselves in the purpose of these MPA key outcome measures. So we'd like to elevate a set of measures, 5 or so, that cut across the different MPA goals and strategies. And these measures will serve as a mechanism for us to track MPA-related impacts for older adults and people with disabilities. And we're thinking about these measures as a method to track population-level impacts over time on key topics such as housing, homelessness, behavioral health, and the workforce. And these measures also present an opportunity for us to collaborate across state departments and with groups like this research partnership. So we're able to bring together different groups of subject matter expertise in different fields to address these multifaceted issues. And we need those different perspectives to be successful in addressing issues related to older adults and those with disabilities. And then finally, a critical purpose of these MPA key outcomes is to serve as an input into policymaking and program development. So as we track these measures and better understand which way kind of the dial's moving, how much progress we're making in these areas, we'll be better informed and have data to share with our stakeholders and data to help drive those policy and program development decisions. Next slide, please. And as we think about developing these key outcomes, we like to ensure that they're related to criteria that we think are important. So the outcomes should be created with the MPA in mind. What outcomes offer us the greatest opportunities to measure progress for MPA-related goals and strategies. They should also align with key policy priorities, promote equity for historically underrepresented communities, and be achievable. I think this is really important as we have our discussions today. What can we realistically achieve during the duration of the MPA, which is by 2030 with existing data sources, then finally be meaningful. These measures should be meaningful for adults with disabilities, older adults and their families. Next slide, please. Thank you. And I want to provide some background on the process up to this point regarding the development of these outcome measures. So 3 work groups were developed to focus on specific subject matter. And the charge of these groups were to partner with CDA to develop and provide feedback on potential outcome measures. And the group has had some initial thoughts on what data sets we can leverage, potential data gaps, interventions, or programs to serve as drivers of these topics, what factors we should consider. And that's what we're going to present to you today for your feedback. But as this process continues, the work groups will work closely with CDA to develop recommendations on which outcome measures we should kind of move forward with. And I'll provide more detail on what will make up these recommendations later this morning. But if you're interested in joining one of these work groups, please let me know. We'd be happy to have you. And after our discussion this morning, I'll also provide details on next steps. Next slide, please. Thank you. I want to provide you with an update also regarding our efforts around accessing data sets to help measure these outcomes. And as a work group leads present today, you'll hear more detail about these potential data sets. But I did want to highlight an affordable housing related data set that I think can be really helpful as an input. And this, for context, our data dashboard for aging includes 2 indicators around housing, affordable housing, supply and housing affordability. And we have a placeholder for homelessness and are currently partnering with the Department of Public Health and the Interagency Council on Homelessness to fill that placeholder with HDS data. We also received feedback from stakeholders about the need to acquire data which separates affording housing and supply by the type of subsidy, and if the subsidy targets older adults and people with disabilities. And that led us to connect with folks at the National Housing Preservation Database to acquire data which does separate affordable housing by those federal subsidies. And we're currently working this data set into the data dashboard for aging, but together with data on housing affordability and homelessness in this data set, these data will help us identify gaps between affordable housing need and supply for older adults and those with disabilities. And this slide displays a preliminary example of what these data show. And this example is only related to Section 202 subsidy, and that's targets low-income older adults. We could conduct similar analysis for the 811 subsidy, and that's targets low-income people with disabilities. But this example displays the number of affordable housing units per capita based on the population of folks over the age of 60 who are below the federal poverty level. And we roll this up to the regional level, but we have these data at the county level. And the Greater Bay Area has a large supply. The San Joaquin Valley has a lowest supply just based on this one program. But I think the bigger takeaway is that as we compile and integrate these different types of data sets, we'll be in a much better position to answer some of these key questions and really start to make progress on these key outcome measures. Next slide, please. This is an example of our data dashboard for aging housing affordability indicator. And this displays the percentage of older adults who spend at least 30% of their income in housing, whether that's renting or ownership. And as you can see, about 60% of folks who rent spend a third or more of their income on housing. It's pretty consistent over time. It's a high proportion. Now I want to share these examples with you today because they might be helpful as we think through and discuss key outcome measures. These examples may be helpful concepts we could build on going forward. Next slide, please. And so we'd like to hear from you today. And Bella, Zia, and David will walk you through some draft outcome measures that we've developed. We want to hear your thoughts about such things as, are there better measures we should consider? Are there data sources? How do we link these outcomes to initiatives that are currently underway? How can we address equity and disparities? Your feedback is going to be extremely valuable because we're going to use it to help determine what outcomes we want to recommend to CDA leadership. And after our discussions, I'll discuss next steps on these efforts and opportunities for you to get involved. So with that, I'm going to hand off to Bella, who will introduce draft measures related to housing, homelessness, and transportation. So take it away, Bella.
Good morning, everybody. Thank you for that introduction, Ross. And I was also going to introduce a colleague of mine, Derek Christopher, who's a postdoctoral fellow at the Sieper Institute at Stanford, an expert in housing and homelessness, and he'll be presenting one of these slides today. So shall I share my, oh, great. So let's just talk about the key outcomes and drivers, and Ross did cover this to an extent, but an outcome is what is the desired policy outcome, and then the drivers are what inputs will we use to drive progress? What levers do we have that we can pull that would lead to our desired outcome? An indicator is quantifiable metrics we're going to use to measure the progress towards our desired outcomes, and the quantifiable metrics we use to measure progress towards these. Factors, and when we're putting them in statistical models, we call them covariates or confounders. And what predictors should we put into our models to help us understand whether or not a particular intervention has resulted in a better outcome. And then the targets are what data point should we have for an indicator by 2030. And you'll see on the slides, we have very ambitious targets, but sometimes it's good to have sort of an intermediary goal that's achievable within a given time frame. And so we'll be talking about sort of intermediate targets as well. And then the next topic is what data sources do we need to rigorously answer questions around what are interventions doing, what interventions are both most effective in helping us reach our target, and which have the best sort of cost-benefit ratio. So for example, an intervention may be very effective, but very, very costly. And so looking at which interventions get us where we want to go most effectively and efficiently. The next is talking about data gaps. Sorry, can we just go back really quick? They're talking about data gaps, and what data do we need to answer these is covariates and research gaps. Where are the gaps in the research? Thank you. If we can go to the next slide. So the first key outcome we have is that no older adults are severely housing cost burdened. Older adults in this case would be defined as those over 65, although there may be some cases where, say, somebody with a disability may enter into that definition earlier. And severely housing cost burdened is when the individual household spends more than 50% of their household income on shelter, on housing. The current interventions that we have in place are rent subsidies targeted to older adults, and obviously below market rate units. An aspirational intervention that we've been thinking about and talking about isn't just subsidizing the units that exist, and Ross brilliantly showed that even if you subsidize units, if you only have 60 units for 1,000 people, there's a very long line for those subsidies. So targeting an adequate and even abundant supply of high quality, accessible, affordable housing in close proximity to amenities and transit. Things which contribute to being cost burdened or not, and again, Ross showed this information, is whether or not somebody owns their home or rents. Renters are much more vulnerable with respect to being cost burdened, and they have much less control over the price of their housing. And then the near-term target is a 20% reduction in the fraction of older adults who report being severely cost burdened. Potential data sources we've been talking about, and I was very excited to hear CDII is moving forward with their program. Would be Medi-Cal. The Federal Statistical Research Data Center has microdata, which can be used to do really rigorous research, looking at exposures and outcomes on housing, income, health, and other social services. SSA and ACS data are in the FSRDC, and then also looking at the supply of subsidized and vacant units. Data gaps, without that kind of micro data where we can really control for individual income, circumstances, and demographic features, it's very difficult to rigorously answer this question of which interventions are most effective. And then, on the same vein, the research gaps are really secondary to this lack of access to microdata. Next slide, please. So, and again, this is predictable and true of many health outcomes. Renters over 65 are more vulnerable to being housing cost burdened than individuals who own their homes. And Ross showed that on the slide before. And then individuals who are Black, Hispanic, and multiracial are more vulnerable to being severely housing cost burdened than other individuals. And so many of these programs, as we've talked about, are targeting particularly vulnerable communities. Next slide, please. So the next key outcome is an affordable housing supply. So we want to, how can I say this? If you have money chasing a limited number of housing units, it's very difficult to move the bar. And so one of the most powerful levers we have is to ensure that there's enough housing that those who need it can get it. So one of the indicators we have is the number of subsidized units per 100,000 adults over 65. With incomes below the California CEI, and with a particular metric for those who rent. The interventions that we have now are subsidizing the housing units that exist, but increasing the supply is an extremely important intervention. And then the factors that we want to control for are the ability to distinguish housing units by type. So there are, very low, moderate, and these different tiers are harder and easier to build. And so really having a bead on what those tiers are is an important factor. And the target is to see a 20% reduction in the fraction of older adults who report being severely housing cost burden with a target vacancy rate of 6%. There's a lot of evidence in the econ literature that if you hit a vacancy rate of between 6 and 10%, that's kind of optimal. It accounts for people moving, there's some flex in the markets, and people can find housing. These are the data sources include the numerator from the National Housing Prevention Database, and then the data sources I had discussed before. And as before, the really rate limiting step has been access to microdata. And so again, we are really excited to work with the state to have really rigorous research that answers the questions of what is the most effective way to reduce housing cost burden in older adults. And then I believe Derek is presenting this slide. Derek, are you?
Happy to do so. Yeah, first just want to say thanks for including me. I'm really happy to kind of contribute my expertise to this group. There's a lot of important work going on, so I look forward to getting into this. Yeah, so I have some expertise in studying homelessness and housing outcomes of especially socioeconomically disadvantaged populations. And one thing we know is that the homeless population is aging. So people experiencing homelessness may have longer experiences with homelessness and may be kind of more entrenched in the system, which kind of implies a unique need for this population specifically. And of course, there's the issue of this population's susceptibility to harm in the environment due to elements due to underlying health conditions that put them more at risk. So this makes data not just utilization of services, but on things like their health, even more essential in terms of homelessness reduction and prevention. So there's this issue of, well, not having a counterfactual, a kind of comparison group. It's one kind of data issue, coupled with the issue of not having data on these related factors, which we know to be potentially quite important for homelessness reduction and prevention due to the multifaceted nature of the issue. So in terms of a counterfactual, basically what we know is if you're not served, then you're not observed. So this makes having more comprehensive individual level data from a combination of sources, as Bella has discussed already, all the more important. And then related to unrelated factors, the issue is we're not going to know kind of what treatment works or what factors improve or worsen if all we have is data on when someone shows up seeking these services, seeking help. We also need information on experiences both before and after they sought help. So this is one of those places where this microdata that we as researchers need is incredibly important. This is one place that Bella mentioned, the Census Bureau's Federal Statistical Research Data Center, FSRDC. This is one place where I truly believe that they could be a lot of help. The Census Bureau also already holds a lot of data on these kinds of outcomes, but it does require a lot of collaboration, agencies partnering with each other in order to produce this data infrastructure we need. It's under that infrastructure that be truly incredible for research and reducing this research gap in the area of homelessness, which is sizable, unfortunately. So thank you again for allowing me to contribute here. And please contact me with questions. Pass it back to Bella, perhaps, or.
So this is the point where I kind of want to pause, and we're going to have 3 separate kind of subject matter discussions. But I want to take a moment here to open up to the group and kind of get the reaction based on the slides that Bella just presented. Derek, thank you, Derek. So we want to hear what data are these measures meaningful? Can we improve on these measures? Data sources, equity, any thoughts and feedback you'd have, we would really appreciate it. So please feel free to hop right in, or you can raise your hand. I'll try to look for hands as well. Angie, go ahead. Thank you.
Oh, wow, this is great. It's wonderful to see the efforts here. Lots of interesting opportunities. I was curious about, and I don't have the slides in front of me, but the decision to use 65 as the cutoff and looking at housing, and the other age cutoff was 50 for ending homelessness, which makes a lot of sense given sort of what we know about folks who are chronically homeless and impacts on aging. But I was curious about 65. Where does that come from? 62 makes, HUD uses 62, other programs and services use 60. Would love some more thoughts about that, only because, especially in terms of thinking about equity, older adults of color, LGBTQ plus older adults, because of cumulative experiences of discrimination, have impacts in terms of aging that would make it seem better to sort of lower that age threshold. So I just wanted to throw that out to the group.
I'll start off, and then if anyone else wants to hop in. So I think it's always a struggle, right? Like what policies are in place for like what age groups want to use, what data is out there. And I think if you want to go, can we pull that slide up, please, with that the measure that we're discussing? Sometimes it's based on what data we can get our hands on, Angie. I think that drives a lot of it. And so this I just want to kind of remind myself what data source we're looking at there.
The next one.
Thank you. Yeah, so I think this is one of those actual, like, limitations we have where it's the data is only at that 65 cutoff. And so, yeah, that's, I've been here for about 6 months and I've seen older adult defined so many different ways, 60, 62, 65. I think sometimes it's based on policy, right? Or it's based on, well, what data is out there for these groups.
Got it. Okay, thanks for the clarification.
Absolutely, Angie. And, you know, as we kind of flesh these outcomes out and we get better data sets, because I think generally the master plan for aging is based on 60 plus. So we're going to explore more data sets as kind of our initial thoughts as of now.
Yeah, but Ross, to build on Angie's point, would it make sense for this group to try and get it so that the age is the same across all of them? And it's going to take some time to work on it, but wouldn't that be an important goal?
Absolutely, Steve. Yeah. You know, I think for homelessness, maybe that's different, like the 50 cutoffs works. But generally speaking, absolutely, yeah. If we can get consistent, kind of these metrics consistent and decide one age, maybe 60 plus is the way to go. Absolutely, yeah.
The other question I had was, I assume the 20% reduction was thoughtful, but if we're looking at a population that has 50%, the prior slide, 50% are who are no, the first of the three, where it was the access and affordability. It would seem to me that if it's 50% and we're trying to reduce it by 20%, that means we're still saying it's okay to have 40% of the people struggling with the housing cost burden. And so maybe where we're having the targets, could we have it by a certain time frame so that we have a different number by 2030?
Thanks for that, Steve. Absolutely. I'm definitely open to that. We're thinking about like what's realistic. Setting these targets is kind of challenging, right? We're thinking about what's realistic by 2030, and absolutely we're open to that. I don't know if Bella or Derek have any other thoughts there.
Yeah, I mean, I'll second Ross's comment. Obviously, I think all of us want to see these problems eliminated, but they've proven pretty intractable for decades. And so we did want to set a target that we thought at least there's a possibility of achieving. And certainly, I mean, it's a floor, not a ceiling. If there was, huge changes in housing policy, which unleashed massive amounts of supply, we could see this change, things like that. But we just kind of tried to set something we thought was feasible.
Yeah,
I was going to let Derek address the question about the age of 65 and the data that are potentially available and how that might be modeled.
So some of these age decisions are challenging to make in part because of data availability and data accessibility. That's part of why I and my own work and this group I know has been emphasizing the importance of a lot of this microdata and a lot of this administrative data, is that when we as researchers can get get access to that kind of thing, we can effectively model trends and outcomes, model a program effectiveness as a function of age. And we can do that depending on data availability. We can do that kind of by year. And that could even allow for a comparison of the effectiveness of certain interventions or improvements or even worsenings of conditions as a function of age year by year. In that case, we would be able to, take this age 50, see, okay, what's happening for this group on every margin, what's happening, take age 62, what's happening on this group for every margin, 65, what's happening on this group for every margin. But a lot of the more technical side of things is that a lot of the existing data that researchers have had access to is kind of clustered in these binned groups of 65 plus or 50 to 55 or something like that. And with that, you're much more limited in terms of what you can say about a specific age data point.
Thanks, Derek. I didn't see any of their hands, so maybe we could turn it over to Zia. Oh, Kate, please hop in. Thank you.
I think you need to unmute yourself.
So sorry. I'm realize that we're focused on the outcomes, but I want to just go back to what Derek said in terms of data gaps and looking at people that cross these silos of data. So people that might be unhoused and have transportation problems and have mental health problems. And so looking at also the importance of tracking across those entities. And I realize that's not the focus here, but I just want to reemphasize Derek's point about that with the gaps.
Yeah,
Thank you, Kate.
I agree. This is incredibly important. There's the issue of, as I kind of tried to mention, the issue of where do we observe these people in data, and if they're some of the people who are missed by even the administrative homelessness management information systems data, we can't observe their outcomes, we can't observe their trajectories, we can't observe the effectiveness of policies for them. But there are, other entities. The California Department of Healthcare Access and Information has done some recording of people's housing statuses when they show up for hospitalizations. So in that instance, we would be able to have information on people's health. And if we compare that with data, especially on homelessness services and other outcomes, like I said, much of which the FSRDC does actually have already, then we can ensure that we've got a more holistic view of the population at hand here. And I think that's incredible. In addition to, as I mentioned, assessing, what factors are at play in perpetuating this kind of intractable issue of homelessness that we've observed only increase over the last decade, at least.
Thank you, Derek. Kate, I see your hand still up. Did you have another question or?
No, I'm not doing well with technology here. So I apologize. Let me lower hand. Sorry.
So I think we can hand it off to Zia at this point, and Zia is going to present some outcome measures related to behavioral health. So take it away, Zia.
Thank you so much, Ross. First of all, I do want to sort of thank and congratulate the state and Sarah and Susan and Secretary Ghali for the tremendous spotlight on behavioral health, but also the $50 million commitment. I think that'll go a very long way. So thank you to all of you for making that happen. Can you go to the first slide? Thank you. And I think Bella and Ross, you have done a very good sort of overview of the outcomes and drivers. As we think about behavioral health, I think there are a few things that I want to sort of preface or frame as we dive into the outcomes. First of all, we look at this from two lenses, the population lens, where you're talking about quality of life, wellness, and so you'll see some indicators, drivers, and outcomes that fall into that population or that population level framework. And then there are outcomes and indicators that are more on the program level, and there we are sort of primarily seeing focus on access and needs and unmet needs. And I think these two lenses are critically important. And the reason is that behavioral health is truly multifactorial, and it's nice to even see how the interplay between housing and behavioral health and caregiving and behavioral health, and many of the programs that the MPA is providing, you can even think about food insecurity, that plays into behavioral health. And so how do we measure such a global health indicator is a challenge. And I think a strategy to go at population level and focus on quality of life and well-being is appropriate when dealing with something like that is so multifactorial, because there may be many interventions that we think are having a positive impact in that direction, but there are others that we don't even fully understand. So I think that's the advantage of doing a population level analysis and lens. Now, the disadvantage of going at the population level, which is there often is a little bit of a lag between the interventions and that outcome translating into data that can be measured in surveys or other population level indicators. But that's something that we have to acknowledge and live with. But to supplement that, we also then have program level data and program level outcomes that are more focused on things like providing better access. So just wanted to sort of provide that framework. I think, our challenge was how do we then balance these two levels of outcomes? And then what is the best type of data and measure? And I'd love to get feedback from the group on those sort of questions. Next slide. So let's start with some of the population level or quality and well-being, outcomes that we think about. And we have a handful of those. So increasing community support and connections is an important measure of sort of, especially for the elderly, in terms of their civic engagement and social cohesion. And there is data on these measures in the California Health Interview Survey, and you will see the California Health Interview Survey appear in many of our data sources. But I would love to learn about other data sources that you're all familiar with, and then what types of outcomes or indicators we can draw from those. Can you go to the next one? Loneliness is, again, is I would think is more of a quality of life and well-being and a population level measure. While there isn't a specific loneliness question or questionnaire or data point that we can get to, I think as a proxy, we're looking at things like suicidal ideation. It may not be the best connection or the best measure, and would love to hear more from the group. But there are measures that look at suicidal ideation in the California Health Interview Survey. And again, this is multifactorial, like suicidal ideation or loneliness is not something that is associated with a single factor. It could be due to mental health illnesses. It can be due to situational things like homelessness and housing instability. So again, multifactorial, hence the need to look at multiple different approaches to try to quantify it. Next one, Ross. This is another, I would say, population level quality of life measure. Percentage of older adults who self-reported psychological distress, and distress defined as feelings of nervousness, hopelessness, restlessness, and depression within the last year. This data is available through the California Health Interview Survey, and there are different factors that you can start to break it down by. You can look at gender, you can look at race and ethnicity, education, income, household size, disability status, immigration, language, and work status, etc. And we actually have some of this data in our data dashboard. If you want to go to the next slide, Ross. And Terry, thank you if you're on the call for pulling these together for us. This is very helpful to sort of not just have our, the data points that we're talking about, but to really see them in action in our current version of the data dashboard. What's interesting is if you look at this data on this dashboard right now, total population around 4% reported psychological distress in this survey item. But if you look at some of the patterns that are emerging, the rural population reported this at almost 2 times than large cities or other small cities. We also see that those respondents who had one disability, they had a much higher percentage of response on this questionnaire as being positive, so like 24%, far higher than the general population. This data also then helps us, focus our interventions appropriately to those populations who will benefit the most from it. And then we can also see the county by county variation in the responses. Next one, Ross. Now, the flip of the previous question is increased life satisfaction. It's different from psychological distress. Of course, it's a broader measure. It looks at life satisfaction, not just psychological distress. But this data is also collected from the California Health Interview Survey. And again, I would put this in the population level sort of quality of life measures. And we can, break this data also down by the same factors as we had in the previous one, by age, disability, race, income, all of those other questions that are available in the California Health Interview Survey. And we can, of course, decide, what should be our cutoff? Where do we want to sort of see the population trending towards? Can you go to the next slide, Ross? So here's data from our current data dashboard on aging. It is a little stale, it's from 2018, but at least it gives us an image of what this data looks like at baseline. And it's focused on adults 60 and older. And you measure it by those who reported 8 or higher on the scale of 0 to 10. That's the cutoff that was used in this survey. And if you look at the total population in California, 62% reported a life satisfaction rating of 8 and above. But you see tremendous differences between both race and household size, and we also see differences across different counties, reporting a higher life satisfaction or a lower life satisfaction. Can we move to the next slide, Ross? Okay, and now we're getting into the second sort of big domain as I described, which is more about access and unmet needs. And these can often be tied to program level interventions. Program level interventions like efforts to improve behavioral health care through clinical settings or non-clinical settings and community-based settings. The data point here is arrived at from the National Mental Health Services Survey put out by SAMHSA. And we can break this down by the different age groups served and different states. So perhaps an opportunity to compare with other states also. And it's basically the number of older adults and disabled adults with unmet behavioral health needs. Go to the next slide. So here's another measure that talks about improving access. A number of behavioral health providers that serve older adults and disabled Californians. And you can have this by population metrics of how many providers per 1,000 population that is participating in the Medicare and Medi-Cal program. And this data is also available from the National Mental Health Survey. Again, it can be broken down by different age groups and also by different states. During the pandemic, we've seen tremendous opportunity and uptake of virtual care delivery. And if you think in the broadest sense, the friendship line, which is designed to help social isolation and create community engagements, is a great example of how technology and telehealth can be used, both in the general well-being and space. And then, of course, we've also seen the adoption of video telemedicine for providing care to patients who need access. There's tremendous sort of, I would say, pockets within California where there is very little access, especially to specialty and subspecialty services. Things like geriatric psychiatry are very scarce. And I think there's options to use the virtual modality to help provide those services equitably across the state. And so we want to adopt this as a key outcome and then have the ability to track it. Today, this data can be extracted from the SAMHSA's National Mental Health Services Survey. And it has an item that talks about the treatment approaches such as teletherapy that are being used. Next slide. And then on the other end of the spectrum, as you think about severe mental health and some of the needs of that population and crisis care, of course, a lot of that care is delivered through the emergency departments and hospitals in our state. And there's opportunities to leverage data that HCI, which I guess, and CDII is going to be collecting on access to care in ERs, the diagnoses, the types of behavioral health diagnoses that are being given, and then what are their outcomes, whether these people are being referred, admitted, and I think that can really serve as a marker of improving the access to care, and also, I guess, as a measure of like how much crisis care is happening, especially in this population. When we think about behavioral health, cognitive care goes hand in hand, both due to the combination of behavioral health issues in the population of dementia patients. So you have to think about these two things together. As a reason, I think it's important when we talk about behavioral health to also have some cognitive care goals and measures included in that work. And I think the number of older adults and disabled adults who receive cognitive care can be measured. BRFSS, which is a survey that's put out by Medicare, allows us to measure Alzheimer's disease and healthy aging indicators in the response of older adults with cognitive decline who have at least had a conversation or a diagnosis by talking to a healthcare professional. And you can again break this down by different age groups, gender, and then states, because this is national data. The next slide, Ross. So here's our DDA indicator on the unmet need for cognitive care, which sort of addresses that issue that I was just talking about. And you can look at this from different geographies by different age groups, and it's available for multiple years. If you look at this snapshot that we have today, only 25% respondents report that they've have had the types of services or assistance that meets all their needs. So that helps us identify a gap, and then we need to agree as a community, like at what number should we be targeting that people are having all their needs met, or at least most of their needs met. But if you look at not at all, that's 12.6%. So I think there's opportunity to use a measure like this that quantifies access to care and unmet needs, and then track that over a year as a reflection of the multiple types of interventions that we are developing to provide better services in this population. Okay, thank you so much, Ross, for advancing the slides, and I hope I kept us on time. I did have more slides than my other colleagues, and I would love to sort of engage in a conversation with all of you on what are some of the best approaches.
Thanks, Zia. So we could open up for the conversation now. Appreciate it. Go ahead, Heather.
Hi, thank you. Hi, Zia. Thank you so much for your presentation. That was fantastic. I really appreciate how comprehensive it is, and in response also with the fact that we're getting more funding in this area. It's very exciting. So I was particularly interested in two things. One is, did you consider looking at quality of life as a broader indicator of well-being than life satisfaction? Because I'm thinking about the different elements that go into quality of life and its relevance in gerontology in particular to so many other indicators of health and well-being. So that's one thing I was curious about. The other thing was I was so excited to see your ideas around comparing access and issues across states. And I think that's going to be so important as we roll this out and look at how the population changes, but also in concert to what we're providing in terms of services and support. So thank you for including that.
Thank you, Heather. Those are both excellent points, and I will follow up with you.
Okay.
I think Elizabeth's next. Go ahead, Elizabeth. Hop right in.
Yeah, that was really, really fascinating. A great presentation. Really appreciate it. I really liked looking at, I think they were the life satisfaction and psychological distress tables, and being able to see, who's responding to what where. I noticed between those tables, the results were grouped differently. I think for life satisfaction, it was at, so looking at, I can't remember which one was which, but one of them was
pull that slide up?
household. Awesome. Yes. So that's race and household. And then the other for psychological distress was sort of urban, rural, and disability status. And I don't know if there's a data limitation, but I'm wondering if you've considered, would it make sense to use these sort of same groupings, to see these indicators across, right? So to add, urban, rural, and disability into life satisfaction and the converse, and just to get a sense of what's happening where and how, and sort of a picture.
No, Elizabeth, thank you so much for raising that point. And I think we have our data guru Terry Shaw on the call. If Terry can be unmuted, I think she has something to add to the conversation. Terry?
Hi, folks. Yes, I put a comment in the chat as well, but exactly to your point, Elizabeth, we try to provide as rich a set of characteristics for stratification as possible, depending on the underlying data set. And in this case, these slides are just illustrative. I tried to, the list of characteristics, you see the drop-down menu there for characteristic is very, very long. Showing all of them simultaneously would be unreadable. So I tried to pull out interesting ones for illustrative purposes, but if you go to the live, these are all from the dashboard, you can see the link is right there. If you go to the dashboard, you can select the characteristics of interest and compare them across the different indicators as you like.
That's brilliant. Thank you so much.
Thank you, Terry.
Thanks, Terry. I think Steve was next. Go ahead, Steve.
Yeah, hi, Zia, great. I'm assuming you're using the NISDA survey from SAMHSA, you know, the National Survey of Drug Use and Health, when you're referencing the mental health surveys?
I think that's one of the surveys.
Okay.
Yeah.
Okay, well, a couple of questions. One, I noticed you're highlighting a lot about access, but wouldn't it also be important to highlight the availability? Because if we identify somebody needs something, but there's you know, a 6 week or an 8 week or a 10-month wait list, it's not helpful. So I think we need a proportion there. And then the last,
couldn't agree more. I think access versus availability are always, you know, two different things in the real world. You're right. Sometimes just by virtue of having a therapist in your community, you believe they have access, but if there's a 9-month, you know, wait list, virtually there's no access. So
especially as more behavioral health folks are not taking certain kinds of insurance. So this is an ongoing issue in the behavioral health world. And last thought, in terms of the congregate care needs, when you're saying meet all needs, that's related to their congregate care issue or their whole person care issues?
Yeah, I think it's the whole person care frame that is being assessed.
Okay.
But Steve, if you have any thoughts or pointers on how to measure availability, I think you could probably either do it through a survey to identify like how long are people waiting to be seen or get treatment.
Healthcare Services has that info, and every county had, yeah, and every county has it, as well as the Department of Healthcare Services. And
okay.
And while I love the idea of comparing us to other states so we can all realize that we're out in front, but would it also make sense to compare county to county? Because if we develop some pilots, we may want to, you know, focus on the ones that are the most in need.
Couldn't agree more.
Okay, thank you.
Thanks, Steve. I think Bella's next. Go ahead, Bella.
Thank you so much for that presentation. It was great. I just had a couple questions. One is, I know that you know, the sort of life satisfaction and a lot of the data were derived from surveys, and it might be interesting to think about a proxy in the medical record, for example, you know, thinking about access to microdata. Where we can use something that is more frequently and reliably collected as a proxy for these things. And it's less precise, you know, if someone reports they're happy, that's more reliable, but, you know, sort of medical events tend to be more broadly collected and more likely to be collected. And I haven't really thought about what those could be, but it'd be neat to find them. And then the second was the patterns with geography were really interesting. And I wondered to what extent you think that might be actually a measure of socioeconomic pressures or resources, you know, because rural areas are typically have fewer resources or more socioeconomically deprived, and what might actually be geographic factors, things like, you know, living in a walkable, tight-knit small town where you can see people frequently and you just have more social cohesion. So I thought that would also be a really interesting thing to kind of try to tease out, is why is there such big disparities by geography, and what's that really measuring? And might there actually be something about the way communities are structured that impacts mental health? So it was really great. Thank you.
No, Bella, as I'm thinking about what you're pointing out, I mean, these are amazing opportunities for those sort of what we call the research questions, yeah, for like doing some pilot work. really slice and dice the data from multiple perspectives while controlling for different covariables, cofactors, and look at these associations. Like you said, city planning and housing has an impact on quality of life and behavioral health for sure.
Thanks, Bill. That was great feedback. I see Catherine's hand up. Go ahead, Catherine.
Hi, good morning, everyone. Sorry for the camera off, but my internet's a little unstable. Hopefully it'll last for a few minutes. First, I just appreciate the presentation and the framing of the need for both the population level and the program service data. It just seems that those two go hand in hand, and even in the comments that others have made subsequent to your presentation, we see why we need to look across these different data sources and integrate and supplement, complement where we can. So all of that's really great. And some of the data, I mean, we know there's a lot of limitations, but I think that the examples that you brought up are a really good starting point to think about what the measures might be and where else we can find more robust and, systematically collected whether it's medical record data or population level data or service provider data, so on and so forth. Specific thought or question I have is regarding the access measures and thinking about going even more upstream and thinking about the training of the behavioral health workforce and whether we can consider some measures of the pipeline, because in order to improve access, we're woefully unprepared in the behavioral health workforce in general, and even less well prepared when it comes to specifically geriatric behavioral health. So I don't know if we can look at some data from HCI around workforce development programs, programs that are incentivizing people to go into behavioral health provider positions that are geriatrically specialized, but also in thinking about the geographic issues related to that access of workforce. I want to see a map of those underserved behavioral health areas across the state, but specifically to geriatric, focused. And so those are just some thoughts I wanted to bring to the table, and it's going far upstream, but I think we need to think across the whole continuum at the point of service delivery, but also at the inception of, where is this workforce going to come from that can address and respond once we get these programs in place and we grow them to really address the needs of older adults and people with disabilities.
Catherine, that question is a perfect segue to our next presentation, because David's going to share similar data. And again, there's a lens of caregiving and workforce that impacts older adult care. And I think there's going to be some interesting ideas there on how to measure caregiving and workforce for behavioral health. But I couldn't agree more with you that we have to address this from multiple perspectives. Availability, like Steve said, access to care today, virtual modalities, how do we leverage the existing workforce to its best, but also how do we, create a more robust workforce into the future. So David, over to you.
Before we move on, Zia, I think I see Donna's hand up.
Oh,
go ahead, Donna.
Hi, Zia. First of all, thank you for this wonderful presentation. I was wondering, are we having any measures looking at multi-generational households and how they might be a strength in this area, so that we look at the ages of the people in the household across for generations, or consider it?
No, I think that is a great idea. We saw a little bit of that, I would say, signal in the well-being data, where we saw that people who live in a family housing situation had higher well-being ratings. Would love to sort of understand with you and Dr. Keitzman and others who are doing this work, how do we start to peel that back and understand the multi-generational aspect of this?
Thank you, Zia. I think we can move to David, who's going to present measures around the workforce. So I'll hand it over to you, David. Thank you.
Thank you, Ross. And thank you to our other two committees for doing such great work on this program. Catherine, great question lead in, because as we've already discussed in previous meetings, we're focusing on the issues around workforce in terms of the potential sources and growth of those programs, since it is a major issue across all levels of care for older adults at this point. But we also want to reinforce, while this says workforce, we're really including both the informal and formal workforce in our approach. So we've started focusing on, this group has been focusing on 3 substantive areas: the family caregiver drivers, the issues around the direct care workforce, and then more calling it the broader healthcare workforce for aging. So once again, we're using, and thank you, Amanda, for moving us through this. We're using the same framework, looking at goals, indicators, et cetera, that you've just been hearing, and looking at some of the key elements aligned with some of the recommendations that came out of the Master Plan on Aging metrics. So if you could go to the next slide. One of the things I wanted to share as we're doing this is that we're building on the specific goals that were called out in the master plan, but then looking at individual metrics aligned with both the existing resources we have in the state, but also those that are coming online. Before I go further, though, let me just thank again our subcommittees, Steve, Nari, Heather, Donna, for the great input. We've been trying to work on this as we move along. So this is still quite a work in progress, but I want to thank them for their thoughtfulness in looking at these areas and calling out, building on some of the work that was done through the data dashboard and what Terry developed, and now we're put into this framework. So in particular, if we just start with the family caregiving area, we have several different items that we're considering for the metrics within that area. Both strain, and thank you, Heather, for calling that out, as well as burden in this area, and the different types of pressures on family caregivers that go into that. And particularly as now with the caregiver resource centers under the direction of the Department on Aging, we're looking at that as a wonderful source, because it is statewide, of where we can track family caregiver resources and data. And coming forward, CalGrow's program. So we've indicated a number of measures that are available, particularly trying to use California Health Interview Survey wherever possible, the CareNav from Family Caregiver Alliance and the Caregiver Resource Centers is a wonderful new resource. And then several other surveys that will be coming online. We're particularly looking forward, as we understand it, there'll be the statewide survey of older adults done by the department, and now an LGBTQ older adult survey. So we see several different potential sources, some that are already in existence, others may take a little more work to put together. So this was the first way we've been doing this. And again, having people like Donna and Heather and now Angie, I'd like to call out. Angie, thank you for offering to join this group. We have several national experts on this, so I think we'll be able to refine these measures very nicely. If you go on to the next slide, this is just an example, aligning it with some of the data that have already been there from the data dashboard, so that you see some of the metrics we've had and can build on. If you go to the next slide, as we look at the direct care workforce, the primary metric that people have been using that we already had from the data dashboard is number of in-home caregiving workforce individuals per 1,000 adults over the age of 60. So again, this was a metric that was put forward, and we have had that. But there are several other sources, ways that we'd like to look at to consider how we measure the number of individuals, whether it be direct metrics around number of employed home care workers, looking at the IHSS registry, number of ways that we can track these issues, even if they're proxies. So primary mechanism so far has been around Department of Healthcare access and information, grant programs coming online as a way to do this. We've listed a number of factors that could impact this issue, but we haven't really set targets at this point, because several colleagues have questioned, and we'd love input on this, where the standard for number of caregivers per 100,000 older adults was developed from. So we'd like to see if there's specific sources that we can call upon for standardization and allow us to align with national data. Number of different recommended data sources, and there are a few issues that we've already identified. I know there'll be more in terms of data gaps. If you go to the next slide, once again, the data dashboard, this was the primary metric that's been captured to date, but we anticipate being able to do more. And again, thank you, Terry, for calling these out and being able to help refine these measures. And then the third area, if you go to the next slide, is really the broader healthcare workforce. As most of you may recall from the Master Plan on Aging, we had actually proposed the key issue that came out of the deliberations was focusing on geriatricians. And Heather raised an excellent point that number of geriatricians is not growing per se. And if anything, we're seeing the need for more geriatric specific trained individuals across a number of disciplines. So her recommendation to look at a broader set of individuals in different disciplines, I think is very well taken. That will be a key issue. Also, we want to do a deeper dive on the number of folks in behavioral health. So that aligns with our other metrics that the group is doing. And also a great idea of looking at age-friendly health systems as a way of looking at organizational at system level as moving in this direction. So this is a challenging area to get a single or multiple metrics, but to look at the professional workforce, if you will, we think that that will be an important issue going forward. If you go to the next slide, there's two more areas we just wanted to call out that are under consideration. One related to training and how we could measure whether it's the direct care workforce training or even for family caregiving, different measures that would be for numbers of individuals that are receiving different training programs in the state and how those would grow over the coming years. There are clearly some programs that are being developed and are funded, particularly around CalGROWS, that we can look at, but the issue is, can we capture more information on that given the number of different training programs that exist? So that's put out there for a work in progress, and we'd love to have input into this. And the final one, if you go to the next slide, is an issue around how do we look at the changes in specific support. A number of colleagues on the call today have called out that we think a metric in this area would be paid family leave as a key way to see our whole state expanding and in terms of being able to support older adults. So being able to look at changes in that, which are going to be significant. And then, of course, what's already in place, the Caregiver Resource Center network, is a direct measure of the growth in that program. So these last two are more, again, planting seeds and looking for input on them. But I think we're trying to get several core measures that will be easily tracked now going forward. So with that, I'll stop and ask my colleagues if they'd like to add any additional elements and open it up for suggestions from the group on the call today.
Thanks, David. I see Angie's hand up. Go ahead, Angie.
Great. This was wonderful. Very exciting to see all the possibilities here too. I had sort of a larger kind of question for all of the different groups and different categories of research that we're looking at. So I noticed that and I'm new, so forgive me if I'm asking a question that's already been determined from previous meetings, but I noticed on one of the lines of, I feel like it was metric or data source, it basically said quantifiable metric. And so all of the data sources are based on national or statewide quantitative data, which is really helpful for population level data. And I've used it in my own work. It's very helpful. But I wonder if there's ways that we could think even more broadly about how to use different kinds of data sources to identify current gaps, needs, opportunities, and policy solutions. And I can think of 2 examples, particularly relating to housing and caregiving, that we might not capture only by using some of these quantifiable metrics. So for example, with housing, we have, everybody wants the goal of identifying more affordable housing for older adults. Like, clearly nobody disputes that. But one thing we might be missing by only looking at these data sources is what are some innovative programs that are emerging or that exist that don't necessarily come from or that we can identify from these particular data sources. So for example, this isn't necessarily new or innovative, but home matching programs. So there's the potential benefit of having intergenerational matches that keep older adults in their homes or allow a potential revenue for folks who are low-income older adults. Also, there's sort of a link to caregiving there too, different ways in which it can serve as a caregiving support, particularly for older adults who might be more socially isolated. I'm thinking of LGBTQ folks who don't have biological family members or are less likely to have biological family members to provide that kind of intergenerational care. But those are potential interventions and programs that might be harder to identify or examine with the current quantifiable metrics that we have identified. And there also could be structural barriers relating to local ordinances that preclude some older adults from even wanting to engage in these sorts of programs. And so I don't know if we would get information about that by solely looking at these data sources. And then sort of the other example I have is family caregiving is, blowing up right now. There's lots of great opportunities and national initiatives, statewide initiatives in this area that are really exciting. I saw a multi-method, mixed method study a few years ago on family caregiving that, found sort of the obvious things that we have lots of family caregiving need. But one thing it found, by using qualitative data, it also found that some of the reasons why family caregivers weren't exercising some of the policy, solutions that people had identified, like certain kinds of benefits that existed for family caregivers. And so as a result of this mixed methods approach, policymakers ultimately ended up identifying a totally new outreach campaign that was able to actually reframe how they had identified these benefits for family caregivers, as well as, they had talked about doing some regulatory change to make it clear who exactly was eligible for these benefits, just to eliminate some confusion too. And those policy changes arose from this mixed methods approach. And so it's not always necessary. In many cases, population level data is exactly what you want, exactly what you need to answer the questions or the purpose that you need. But I just want to encourage us to sort of think broadly about different kinds of data sources that we could use to achieve some of these goals. And then I'll just sort of leave it at that.
Thanks, Angie. I think those drivers are really important. And on that table that we presented, I think Bella went through it, and so did Zia. Those drivers are critical. We're not looking to evaluate those specific programs. We understand the landscape though, right? So thank you for those points. Those really helpful. Thank you. Heather, go ahead, Heather.
Thank you, Ross. I'm going to respond directly to Angie's comment. In particular, you're absolutely right about needing multiple views and perspectives and ways of collecting data to understand these phenomena. And we did in early discussions think about what is statewide, what is widely available at a population level for the big picture dashboard for the MPA, needing to have some of those kinds of indicators that not only could be robust within the state, but also facilitate cross-state comparisons. But within programs, I think multiple methods and mixed methods are really an appropriate way to go with this. Right now, the Family Caregiving Institute of Davis is conducting a multi-year evaluation with the CCRCs. And we use multiple data sources and approaches. It is a mixed methods approach. And in those, particularly the qualitative interviews and looking at it by race, ethnicity, and different types of caregivers and relationships, we're seeing a lot of nuanced information that can be informing for the MPA and for direction. And I know that within many of these different areas of emphasis within the MPA, there are bodies of work and researchers engaged that are getting more nuanced information. So one of the challenges we need to address as a group, I think, is how do we bring in those other sources of information that may not be population level statewide necessarily, but vital to inform policy and direction and to give us indicators of our progress in the right direction. So I'm really happy you're joining this group and can help us, think through that as well.
Thank you, Heather. Go ahead, Kate.
So this has been great, and I want to emphasize a few themes that have come up. But the first thing is some of the areas surprised me in that the benchmarks are already better than I would expected. And I think to recognize, particularly in the life satisfaction, and there was a lot of variation, but it seems like California is doing some things well. And so start with, what are the benchmarks that give us positive places to leap off from? The second, and this is a theme that's brought up in terms of other methods, but natural experiments and the variation both across counties and across urban, rural. And I think California is large, we can compare to other states, but I think there's a lot of opportunities to look at natural experiments and what some communities, what we can learn from them in terms of things that are going well. The third thing is, in terms of other methods, looking at this was implied by in terms of co-design, co-engagement, starting with the older adult communities, what can we learn from them, and how do we engage them in designing our approaches to the kinds of questions that we're raising. And there's wonderful models of co-design and research. So those are my overarching thoughts.
Thank you, Kate. LaDonna, go ahead.
I was, thank you again for representing our group. Having been on the group, one thing that I know is a little difficult for us, but I think we have to continue to find our data source because our caregivers are anywhere between 20 and 90. And so some of our data sources need to be pulled from areas that we don't normally look at, who might be capturing that the fact that we have caregivers in those younger age groups. How can we go about capturing that information of people who are working, who are also caregiving? Because we, at least for the Caregiver Resource Center, we even hear stories of how early life caregiving leads to homelessness, because they're living with the person, and then when that person dies, they have nowhere to go. And now this is a 50-year-old or 55-year-old who is an older worker, can't get into the market. So we need to be able to capture that information across the state, which then can be, we can use that to say how we're looking at caregivers and the impact overall on their well-being at varied age groups.
It's a great point. Thank you, Donna. I don't see any other hands, so I think we could move on. Amanda, to the next steps is next. Thank you all for this great discussion. That's exactly what we needed. So this is extremely helpful. You can go to the next slide, please, Amanda. So as we move forward, I'm going to work with the work groups to get a couple of meetings calendared per work group. And the purpose of these meetings will be to discuss which outcome measures we want to move forward with as recommendations to CDA leadership. Also, if any folks want to take a lead role on an outcome measure, we'll have those discussions as well. And my hope is that by the next research partnership meeting, which is 4 months away on September 22nd, we'll have developed a set of recommendations and also presented those to Sarah and Susan for consideration. And then CDA leadership will decide which outcomes best align with policy priorities. Go to the next slide, please. And also want to provide some context on what makes up a recommendation as we kind of move this process forward. So we'll have one deliverable per recommended outcome. And that document will include the rationale for the outcome measure, how it aligns with the criteria that I discussed earlier, but in particular, how it aligns with CDA's policy priorities and how achievable it is. I think that's going to be really key. And also specifics on data gaps and sources and examples of what the indicators and visuals will look like. I'd like to have one lead per outcome, but we view this as a collaborative effort. And as we start to conduct this work and get a better sense of the resources and workload associated with it, we may be able to provide some resources to help alleviate some of the time burden that's associated with this work. So again, if you'd like to be included in these work group meetings, please let me know. You can reach out to me directly. And we have some time, so before we move to public comment, just want to see if there's any questions I might be able to answer. Okay, I don't see any, so I think we can go to public comment, Amanda. Thank you all.
Sure. Okay, we have a few minutes for public's comment. So if you are on the phone, you can go ahead and press *9 on your dial pad and you'll be added to the queue. Or if you're on the webinar, you can go ahead and click raise hand and you'll be added to the queue there. But I don't see any hands raised, Ross. So we have some spare time for more conversation.
That's good. I think that the next slide's about the kind of next steps that we have our path forward kind of nailed down. I'll reach out to schedule those work group meetings and we'll start kind of working on what we want to recommend and kind of bubble up and elevate these outcome measures. Just want to thank you guys again for your time today. This conversation is exactly what we needed. We have this information. I'll try to send out some notes to everyone. So unless anyone has any other questions, with that, we can sign off and hope everyone has an awesome weekend. Thank you all.
Thank you.
Stay well, everyone.
Thank you.
Take
Ross.
care.
Thank you.